dear professors and colleagues. Today, I will present our study titled Wave Off, a Mechanism for Physician-Reduced Demand. This research is based on 200,426 outpatient visits from the Department of Cardiology at Zhongshan Hospital. We aim to address a fundamental yet largely overlooked question. When physicians face high workload pressure, do they only adjust service intensity, or do they also alter the structure of demand? We propose a new mechanism, the wave-off mechanism, suggesting that under high workload pressure, physicians may implicitly reduce short-term revisit demand, thereby influencing patient arrival rates. In healthcare operations research, extensive evidence shows that under high workload, physicians will increase service speed, shorten consultation time, reduce per-visit service intensity. However, the existing literature focuses almost exclusively on supply-side adjustments service rate. An important gap remains: do physicians influence whether patients return in the future? In other words, do physicians adjust the demand side? This question motivates our proposal of the wave-off mechanism. On illustrate the literature structure using a seesaw metaphor. On the left side, research emphasizes service speed, focuses on supply-side efficiency. On the right side, our identified mechanism, physicians influence arrival rates by affecting revisit probability. They regulate demand. This suggests that healthcare operations are not purely supply-driven, but involve dynamic interactions between supply and demand. The wave-off mechanism is defined as under high workload pressure, physicians implicitly reduce the probability of short-term patient revisits. This differs from traditional physician-induced demand, PID, which refers to increasing demand. We instead introduce a physician-reduced demand, PRD. This is not a moral judgment, but rather a behavioral response driven by fatigue, limited cognitive resources, workload pressure. Our dataset include Department of Cardiology, Zhongshan Hospital, 200,426 outpatient records during 2020-2023, full linkage of outpatient, laboratory, and inpatient data, complete longitudinal patient trajectories. This allows us to observe revisits, system exit, and medical expenses long-term workload dynamics. The data processing steps are as follows. Match each outpatient visit with the nearest laboratory record. Exclude outpatient visits after inpatient admission. Restrict age from 30 to 74 years. Divide records into two scheduling models. Final sample size 27,649 for imputed model. This division is critical for identification. We focus on 4 research questions. Does workload reduce short-term revisit probability? How do physicians implement the wave-off mechanism? Which patients are most affected? What are the short-term versus long-term consequences? There are 2 scheduling systems. Individual scheduled patients return to the same physician, a dedicated queue structure. Pooled scheduled physicians are randomly assigned. A mixed queue system. Approximately 85% of patients tend to revisit the same physician. This setting provides a quasi-natural experiment. If wave-off is physician-driven behavior, the effect should be significant only under the individual model, patient stickiness. This slide presents the distribution of patient stickiness. About 85% of patients consistently revisit the same physician. This implies physician behavior directly affects revisit probability. Continuity of care is a prerequisite for the wave-off mechanism. Key variables include independent variables, workload, FS sample entropy, dependent variables back within 1 week, leave expenses, commission controls, demographics time fixed effects, prior admission history, sample entropy measures trajectory complexity. Higher sample entropy indicates greater irregularity in clinical trajectory, stronger reliance on continuous care, higher revisit propensity. We employ logit models, revisit, leave, expense regressions, a two-stage EM need admission model, short-term versus long-term workload dynamic models. Need admission model. The model consists of Stage 1 logit model predicting admission, Stage 2 Cox hazard model. Model performance accuracy is 94, 65%, AUC is 80%. Results show that even after controlling for medical need, workload still influences treatment intensity. Core finding: higher workload, significantly lower short-term revisit probability. Moreover, significant only in the individual model, not significant in the pooled model. This provides strong evidence supporting the wave-off mechanism. Mechanism evidence shows, under high workload, fewer diagnostic tests, more medication prescriptions. This suggests that physicians substitute medication for follow-up visits. Additionally, the wave-off effect is stronger for high stickiness patients. After controlling for medical need, higher workload remains associated with relatively insufficient treatment. This indicates that the wave-off effect cannot be fully explained by risk adjustment, short-term workload smoothing. Long-term, cumulative workload exhibits a U-shaped pattern. This suggests that deferred demand eventually resurfaces. Wave-off represents an intertemporal redistribution of demand. We use 7-day lagged workload measures. The results remain significant. This rules out reverse causality, patient self-selection leading to higher workload. We propose that wave-off represents a physician-reduced demand mechanism. In a short term, relieves congestion. In the long term, may increase systemic risk. Policy implications: introduce workload-aware decision support systems. Incorporate behavioral factors into healthcare operations models. Pay attention to intertemporal trade-offs. Thank you for your listening.